it was really, really helpful for all of us, and I know we have lots of questions. And I'm going to start and take the prerogative of the moderator. So, and I would like to include Mrs. Hergrafy as well, if she's still with us, to please join in if you might have something to contribute. So in your perspective as providers, what is the biggest benefit? And I think I heard a little of that in Dr. Rosensweet's response. What is the biggest benefit that comes from compounded BHT products that we don't already have in the FDA approved?
Could I answer that? The startling thing to me as I embarked upon treating women in menopause was the astounding variability woman to woman. It's impossible to come up with a prescription of how much estrogen a woman needs and how much testosterone a woman needs. And every woman after 3 years in menopause with no period needs testosterone or she will develop sarcopenia. How much progesterone she needs, how much DHA she needs. She has to be individualized. And you simply can't achieve that with the currently available products. And then I wanted to clarify that best practices for safety, and that's the bottom line. We're talking about women here. The bottom line is, how safe can we make this efficacious? Without estriol, you're taking away one of the tools that is so crucial. This is available only through compounding pharmacies. That's why I tried to make such a point of estriol and put in, these are the stack of references. Most of them are on the importance of estriol. You can't get these through the conventional products. Just as an anecdote, well, I'm sorry, those are the 2 points I'd like to make.
And this is Lynn Hografy. I fully agree with what you've said, Dr. Rosensweet.
Thank you. We'll take questions from the committee or other comments you'd like to make.
Yeah, I'd like to comment on that. You know, this is a very difficult problem. There is a wide range of normal within hormones, within cholesterol, within many of these biological measures that we believe are associated with outcomes. And if somebody would ask me, well, what's the perfect testosterone level a man should have? Well, I don't know. I could tell you the mid-range of the normal population. You know, an average 40-year-old man has a level of 500. But, you know, whether or not there's differences at the level of the receptor and difference at the level of end organ, does the bone require, you know, a certain level and does the muscle require another level, I think is still really an unknown factor. You know, all we have is the biology of the normal population, pretty much.
I think we need to ask ourselves another question. And that is, are we treating the lab or are we treating the patient?
The other thing is I totally agree with the other two physicians here. And at the same time, there's been wonderful research done on how much estrogen does a woman need to prevent bone loss. This is a big deal. And for that matter, vaginal atrophy. You get into vaginal atrophy, you get into bladder issues galore. This is a big deal. This is the cause of adult diapers. And I can tell you, for a physician who treats women in their 70s, 80s, and 90s, women do not like this. They do not like these Depends. They tolerate them. And at the other end, there's very good literature on how much does it take to overstimulate breast glandular tissue and thus lead to increased breast density. I've dived into that medical literature so deep and have come up with specific parameters. Though I agree, yes, we're at an earlier stage of being able to personalize these as far as laboratory data go, that still at the same time we can come up with wonderful numbers that lead us into safe targets.
Yes, Robert.
Yeah, for Dr. Dobbs. You showed us a slide that had several formulations of testosterone, oral, topical, injection. In terms of a combination of dosage form and site of application, to the extent you can, what do you think is the safest formulation and the best site of application?
Well, I tell patients, I tell men, you're not married to any of this. You could try one. If you don't like it, you can go to something else. We're talking about symptom relief, such as hot flashes, which men can have, sexual dysfunction, which is one of the most common reasons they do present. So I want symptom relief. I want a reasonable number. And we try and we see what works best for the man. Some men like gel. They take it every day. There's no problem. Other men don't like gel. They find it messy. They find it doesn't dry well, and they will often switch to something else. So the importance is to monitor the symptoms, monitor the level, and monitor the end organs as much as possible. So, for example, a bone density is done in every man who's hypogonadal, because even if he says, oh, I don't have an improvement in sexual function, but if he has osteoporosis or osteopenia, that would be the indication to treat for purposes of bone strength.
Dr. Fishman.
Thank you. So I had a couple questions for Dr. Dyson and Dr. Rosensweet, which it seems that what you're both saying that differs from the providers who provide FDA-approved products is also that you're comfortable with kind of lifelong use. You don't see a need. The recommendation now for hormone therapy is to take it for the least amount of time that you would think you need it. And so I'm wondering if that's the case, that do you see any potential problems, or do you see this as once a woman needs hormone therapy, that she will continue to need it or want it for the rest of her life?
When will I stop needing it? When will I stop being a woman?
So
For
it's
as
not,
long as I live, I will be a woman, and I'll have estrogen deficiency if I don't replace it. That's how I feel about it. I know the recommendation is stopping at 60. I'll be 65 on my birthday.
Well, I'm old.
The shocker is that there's new information.
Push the button.
Yes, I can't. There's two others that have their on.
Oh,
So I can't get mine on. Press your speaker button. Okay, good. The latest information is so different than what the public has been exposed to, including the professional. That's why I urge this committee and everyone to read Estrogen Matters. The new recommendations are for life. A woman who stops her estrogen at the age of 80 is going to develop osteoporosis, and rather rapidly. There is no specific reason or recommendation to stop these hormones. There used to be, when the WHI blew up, we were so nervous about it, we say take it for the shortest periods of time and the lesser dose. That no longer pertains. There is another issue I would like to address. I'm so sorry, I'm piggybacking on the tail of the last issue. I did a study a couple of years ago, the last of 54 patients that I had treated and tested in the preceding year in preparation for a seminar that I was giving. And what I learned about these, and these were women who came to me after 3 months to 6 months, and they said, I feel great. Thank you so much. Well, if that's the point, we test 100% of our patients. And what I learned is 25% of them were on doses more robust than I considered safe for the long haul, for their whole life. 25%. These were my patients. 50% of them were on doses that would not preserve their bones. They felt better, but it was not enough to preserve their bones. We know those numbers from the medical literature. NAMS recommends don't test, and they've been doing it for decades. And the reasons began are ancient. There was no test for Premarin. There never has been, and I think that they just haven't discovered 24-hour urine hormone testing. But what I'd like to say is symptom alleviation. While alleviating symptoms of insufficiency and falling shy of symptoms of excess, that's a great clinical tool, but it is not the final answer. Every single woman must be tested so that she falls within targeted ranges.
That's him. He's talking.
Given the variability that you've all experienced in your patients. There we go. You've also encountered adverse events. Could you each describe a recent adverse event that you've submitted to the FDA for contribution to our knowledge about toxicity?
The most common side effect that I see is an elevated hematocrit. And it's basically only in men who take injectable testosterone in which their levels become superphysiological. It's rarely, if ever, seen in a man taking a transdermal compound because the levels don't really get very high. The increase in hematocrit is seen particularly in men who start out with a high crit, and also for men who live in Denver, in which they may have high hematocrits because of altitude. So we monitor this very carefully, and generally we wind up reducing the dose of testosterone, and in some scenarios we might even do a therapeutic phlebotomy. But it is a known side effect. It has physiological understanding. Testosterone increases erythropoietin production, so it's something that can be monitored very easily. The issue of blood clots, we ask about it, but the data is really very mixed about whether or not it causes an increased thrombotic event. I find men stop it. Is that if a man has a good bone density and he does not sense improvement with sexual function because of, let's say, other comorbidities, such as hypertension or diabetes as maybe the cause of the erectile dysfunction, men will self-select themselves out and stop it. And I can't argue with them about this, because if they have a normal bone density, then I'm not quite sure what else I'd be treating.
We have a very rigorous follow-up, an ongoing monitoring situation, and I can't say that I've ever run into an adverse event. I frequently run into symptoms of excess. The women have already been schooled in this, and our whole program includes, they're given a card, and I have an example of the card that they're given to identify symptoms of hormonal excess. And so when they get breast tenderness, we are a no breast tenderness practice because breast tenderness means you're getting overstimulation of breast glandular tissue. So they'll report, and this was mentioned before. So when a woman has breast tenderness, she, in most instances, and not all, she's just on too substantial a dose and she needs dose reduction. Now, having said that, we're human beings. We are vulnerable to illnesses, hundreds of them. Thousands of them. And I have encountered women over the course of 25 years of just treating women in menopause who have breast cancer, developed breast cancer, had breast cancer, then came to see me as a patient. And, there's so many multitude of causes of breast cancer. I assert that hormones is not one of them, especially if you're using doses that don't overstimulate breast glandular tissue. In fact, from first breast cancer cell, it takes 10 to 15 years for a palpable mass, identifiable mass, to develop. So by the time a woman is in menopause, if she's going to develop a breast cancer, she probably has already developed it. But we're vulnerable to illness. But I honest to God, all these 1,000 patients, I haven't seen an adverse event, and we're being very careful with them.
What I have seen in my practice is breast tenderness, which he's also seen, an increase in breast size. Women will drop out if for whatever reason it stops working. And I had a patient who she had sickle cell anemia. She was on bioidentical hormone replacement therapy. And while she was on it, she didn't have to be admitted for any crisis. For some reason, it stopped working. And she just got immediately frustrated and stopped the hormones. But we are dynamic. We're not static. So there are many things that can happen that will change how the hormones are working. If we are under any kind of psychological, physical stress, or getting an accident, whatever, that can change how the hormones are working. So it's also important that women understand that it's a dynamic process.
Phyllis Greenberger had a comment.
I just wanted to mention, well, first of all, I had mentioned Avram Lewin's book at the very beginning, and I do think it just really changes, I think, perception of the WHI. But I'm sitting here and I'm thinking we're having sort of two discussions, because there's a difference between individualized, customized, compounded bioidenticals and factory-made bioidenticals that are sold in great quantity to pharmacists. And also, my understanding is a lot of it is imported from China. So, my comments and Cindy's comments really are focused on those that are not, have not shown any efficacy or safety or approval and are not given by responsible people who are checking hormone levels and are individualizing them and customizing them to individuals' needs and hormone levels. So I think there's two discussions. There's those that, may be safe and obviously effective, and then there's the other issue of all the other ones that come in from outside the country and are just given willy-nilly to people, to women who are afraid of taking FDA-approved ones.
So,
I have a little more comment for Dr. Madison. The interesting thing is about hormone dosage, it doesn't take that much. The medical literature is very clear. I am definitely one who does not restore youthful levels. It doesn't take that much. The amount that it takes to alleviate vaginal atrophy is the amount that it takes to protect the bones. In most cases, there's one exception. Some women need a little more for cognitive function. So if this is what a young woman between her 20 and 29-year-old has in hormone levels, it takes this much to support a woman royally in menopause throughout the rest of her life.
I can also speak from an individual level that I did become afraid after the Women's Health Initiative when I started my bioidentical hormone replacement therapy, and I decreased my dose to like a very minimal dose just to control urinary frequency and hot flashes. But I began to get in trouble with my brain. That's when I began to have the issue of not being able to concentrate for more than 2 hours. So a minimal dose was not adequate to control my symptoms.
And I second that. And like I said, there was a cognitive exception to this. The other thing I'd like to address, and I so look forward to our compounding pharmacy afternoon, because my understanding is that almost every hormone is being produced in China right now, so I could be stand to be corrected, and that they're all FDA monitored along the way. Certainly the hormones that the compounding pharmacists are procuring are monitored at several steps by the FDA. But I'm sure our compounding brethren will speak to this afternoon.
Thank you. We're going to ask give them a chance to ask you questions.
So I have a question for Dr. Rosensweet. So we've heard this emphasis on the need for sort of exquisitely customizing the amount of hormone that's needed. But you also talked about getting to the literature-based standards, getting people to the literature-based standards. But how do we know that there isn't a huge variability in that? I mean, there may be a standard, it's based on some kind of an average that is thought to be protective for osteoporosis, for example, but it may be the case that some women, are protected at lower levels and some women need higher levels. So it seems like it seems a little, I don't know, inconsistent isn't the right word, but worrying about getting to a flat standard that may really not be relevant to all women.
Well, we have several data points to monitor. For example, in that list that I read you about what we do in our practice, and is very common practice, is every woman gets a bone density. And you have to measure different parameters. I mean, we set a standard of how low can you go, but at the same time, she better not be losing bone. And once if she gets osteopenia, then we start seeing, is she urinating out bone molecules into her urine, so we can identify bone loss and address bone loss in a variety of ways. And then the medical literature. Oh my God, this is a big topic. I mean, at the University of Michigan as a senior, we had to take a 6-month course in the medical literature, and I was exhausted. And I loved my white coat, and I loved marching around the hospital. But my God,
I've got to be the bad person here and keep us moving. You had a question.
So we have 4 people who prescribe at some level. And I'm wondering, is there a network of prescribers for compounded bioidentical hormones that are a source of good prescribing information, good evidence, sort of a go-to to guide people who are going to be prescribers, including, our person from the first panel? Is there a network, or is it more an individual practice? I go to my own sources, I look at these, I use this information in order to make my decisions about what I'm going to do, just so we don't miss any repositories of information like that.
As far as I know, there isn't, but there's somewhat of a loose network when I attend meetings that are with other physicians who do rhythmically dosed bioidentical hormone replacement therapy. And I guess they would be a resource for me because I would talk to them or ask them for, research or whatever. But I'd like to bring Dr. Dobbs in because she probably knows about research, and would we really know what's going on unless we look at the receptors? And that's only like experimental as far as I know.
It's really very experimental. We do not know what level is required for an individual man. We have some general things about a population, but maybe it's age-related. Maybe an older man requires a higher dose of testosterone or a lower dose of testosterone. It is an unknown. We generally just want people to be within the normal range. And the question of bioidentical or pharmaceutical is that there's so many options for pharmaceutical. You can measure the level very nicely. So that's why I think most people will use that.
Thank you. A question to Dr. Rosensweet. Regarding bioavailability, we're trying to understand really the bioavailability of these compounded products. You mentioned estriol. For estradiol, we know very well how it can go across the skin. What about estriol? What information do we know
Adele,
about?
a little bit louder. There are a
Yeah.
lot of people want to hear you.
Yeah, my question is regarding the bioavailability of these compounded products. So with estradiol, we have a very good understanding in how it goes across the skin in transdermal products. But for estratriol that you mentioned, what information we have regarding the transdermal delivery of estriol across the skin and its bioavailability systemically from transdermal route?
There's a reference from Dr. Henry Lemon, who started doing research on estriol. He was a professor at the University of Nebraska, and he saw that women who had breast cancer had much lower estriol in their 24-hour urines than young, healthy women. So they started measuring estriol in the urine. Now, because I've had access for almost 25 years to 24-hour urine hormone testing, I can see how estradiol is absorbed by a woman and shows up in her urine, how estriol is absorbed. So I get to see it in living technicolor, the exact level. So I have no issue at all of assessing, just like I can see testosterone levels, the metabolite of the androgen levels, the metabolite of the estrogens. It shows up beautifully in testing.
Urine testing bioanalytically is rather difficult in terms of quantitating. I mean, why not do serum?
Well, estriol is very evanescent in the serum. It comes and goes so quickly. And in a woman that you're treating, you've got this timing issue. You don't know the pharmacokinetics. When did she take her last dose?
That's exactly what I'm after, is the pharmacokinetics. So the estradiol, we have a very good understanding transdermal delivery and how these products, the approved FDA products, maintain a level. To have that kind of, I'd like to get the same kind of comfort with seeing levels measured in circulating levels.
Questions? We have 2 more questions that we can take before we really have to be out of the room in about 5 minutes. So the last 2 committee members, Go ahead.
My question was for Dr. Dyson. You had mentioned, are we treating the lab or are we treating the patient? And I just wanted to make sure I understood. I think what you meant was that we should be treating symptoms and making sure that they're having adequate symptom relief. But it also sounds like there is some testing. So I guess I was wondering if you could maybe describe how it is that a patient comes in, what monitoring, whether it's testing or symptom questions to determine what she should be getting. And also if you can describe the range of formulations. Are we talking about creams or, again, what kind of things are you offering and what do the majority of women probably end up getting?
Yes, my assessment is not much different from Dr. Rosensweet. I bring the patient in, I talk to them for at least an hour, and I explain to them risk versus benefits, the Women's Health Initiative, all the other research that I may have found that indicates that bioidentical hormone replacement therapy is safe. I do a complete physical myself. I do a pelvic exam. I may have to send them for a pelvic ultrasound if I find uterine enlargement. I do bone density testing. I do the labs. I do the mammogram. I have the pap smears. I have them follow up every 3 months. And if they don't do what I tell them to do, I stop prescribing.
You're the last, but not the least.
Yeah, so I think the point that Dr. Dobbs, made about what is normal in terms of hormone levels and the wide range of what might be normal for across individuals, it just makes me wonder when you treat a patient for hormone replacement therapy using FDA-approved medications, these are massively produced formulations sort of fix those. You're talking about measuring blood levels of hormones and potentially making adjustments based on how the patient is responding to, say, FDA-approved medications, right? We're basically talking about precision medicine, right, or personalized medicine. Don't you think that then, taking that into consideration, that compounded hormone replacement might be a more flexible platform to do precision medicine?
Well, there's a lot of dosages that you could use for testosterone that are already FDA approved. Injectables, an example, you can go to any milligram you want, really. The whole issue of precision medicine hopefully will be there. For example, the CAG repeat on the testosterone receptor may predict a sensitivity. So, in 10, 20 years from now, we may be able to say this gentleman needs a higher serum level than another man does. But we are absolutely not there now. What we're dealing with now are serum levels. There is a fair amount of flexibility in the products that are on the market now, with the gels, with the patches. I mean, not ideal. There's not 20 formulations, but that's because Synthroid, as an example, which has a very tight window, you do need multiple formulations because of the toxicity. With testosterone, you really, there's no data to say a serum level of 450 is any different than a serum level of 600. So that's why we base it mainly on, we want to get a man into the normal range. And we want to make sure that his symptoms have improved and his outcomes have improved as much as we can. But I don't really see that a bioidentical testosterone is going to be that different than the formulations that are on the market now. They're all testosterone. Now, the issue of DHT and the issue of, whether or not there should be a aromatase inhibitor is getting very complicated, and I think sort of perhaps beyond the scope of this particular committee, because we can't figure it out in the research world yet. But that's what we're doing. Yeah, on that note.
I beg the committee for 45 seconds of a concluding remark.
Actually, you know what? Maybe you can email it to us. Because if we don't stop, we don't stop, and we don't get a lunch break. So I'm going to thank everyone from the very beginning to the very end of these sessions. We really appreciate your time, your energy, your enthusiasm for informing. And if you have follow-up comments, Lee's box is what I call wide open. We'll be back at 1:45. Thanks again.